Good afternoon, everyone. Happy Wednesday, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, Marketing Specialist, and I'll be your moderator. We're excited to welcome Dr. Sam Kratchman as our speaker today, as he will discuss the use of CBCT imaging to detect and locate resorption and cracked teeth, as well as how to diagnose and predict bone healing in surgical cases. Dr. Kratchman is an Associate Professor of Endodontics and the Assistant Director of Graduate Endodontics at the University of Pennsylvania, in charge of the microsurgical portion of the program. He also maintains 3 private practices limited to endodontics. Before we get started, we have a few reminders for you. At any point during the webinar, if you have questions, please type them into the Q&A section of the control panel and we'll answer them live at the end of the webinar. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. And this webinar is sponsored by Morita. Dr. Kratchman, welcome and thanks for being with us.
Adam, thank you very much. And please, if any issues with the sound or the slides, just bring yourself back on in the little corner of my screen and give me a little thumbs down or whatever. I want to thank all of you for allowing me into your living rooms or kitchens or wherever that may be. Very happy to be here. I wish it was live. It's always better when we could face each other, and I hope for that in the near future. And I promise you that I'm wearing pants, not just a nice shirt and sport coat. So tonight's outline is, as Adam mentioned, is I want to talk about the cone beam, and not just like originally they asked me to talk about the last 2 parts were 3D healing and bone regeneration, but that only appeals to endodontists or surgeons or people doing a lot of surgery. I really wanted to give a little introduction and talk about 2 topics as well, resorption and cracked teeth, where I find that the cone beam is really helpful and just instrumental in helping to make diagnosis. And I can't tell you, a day doesn't go by that in endodontic practice that I'm not dealing with one of those 2 topics. So a little bit about myself. As Adam mentioned, I teach at the University of Pennsylvania 2 days per week, but I also have 3 private practices outside Philadelphia. And I found that the cone beam, I've been using it for the last, I don't know, around 10 years. And it's just been unbelievable to the point where I don't know how I got by without it. I am not a paid consultant for any company. Morita was generous enough and Schein generous enough to sponsor me for tonight's lecture. So I'm going to give a very clinically related presentation. I hope everybody enjoys it, and tips to help you for your private practice. I'm not here to sell any product, but what I show here on my lectures is what I'm using in practice and at the University of Pennsylvania. So people ask, well, the cone beam is an expensive tool. Is it really worth it? The truth of the matter is, I bought the cone beam not so that I could make a lot of money in my practice off it. I charge approximately $150 for a cone beam scan, in addition to an evaluation fee. If I need a cone beam for a surgery or for a retreatment, and the patient is hesitating or they say I can't afford it, I'll do it for free. It's so helpful in making the diagnosis and helping with my treatment plan. I call it my GPS for endodontic surgery. In fact, it's going to help to guide me in what I need to do. I don't care about whether I'm charging or not for the patient, but this just gives you an idea. This is just a column from one particular day in my office. Might have been one of my records where I did 9 cone beams in one day. Obviously, I'm blocking out the patient's names for HIPAA reasons, but the cone beam can pay for itself, and the prices, like with everything, they've been around for a while, so the prices have come down a bit as well with the cone beams. Now, I researched a lot before I bought my first cone beam, and I came upon the Morita basically because it was one of my former residents was practicing in Westchester, New York, and he would always ask me advice about cases, and he would take pictures of his cone beam off on his cell phone, on his iPhone, and send me pictures on his iPhone and ask me my opinion. And I said, Brian, I'm like, that's clearer than any of the cone beams that I've seen. What brand is it? And he said, oh, it's the Morita brand. And we knew Morita from my Root ZX and from various other very high quality products from Japan. And because of that, literally, I purchased the Merida, my first Merida. And then it's the machine that we use at the university as well, both in the endo department and down in the perio prosthetic department. Now, as I said, I have 3 private practices. I'm in the middle of purchasing a 4th practice, building a 4th practice. My first Merida is the 3DE model. It's an older model that still works fantastic. Second model is the 4D. And then in my new office, I just ordered the X800. So these two cases here, I'm showing you, I haven't had personal experience yet with the X800, but I'm very excited to use it when I get it in my new practice. And Marita was nice enough to share these images where you can see the difference. You know, usually when you're looking at implants, and I don't do implants personally, but when I'm looking at scans with implants, you get all this scatter or noise coming off, these reflections off the implants. And with this new X800 model, look how it reduces the scatter. This is very helpful in that whenever you see cases with gutta percha or with crowns in place, you also see this noise. And I'm going to show you cases in a little while about helping to diagnose fractures with the cone beam. And you can see how the noise reduction, yet without degrading the quality, might be able to help us further diagnose cracks. Because diagnosing cracks on a cone beam is something you have to be very careful before you announce to a patient or be thinking that you're going to buy a cone beam so that you can diagnose cracks all the time. When the teeth are heavily restored, when they're implants, when they're porcelain fused to metal crowns, when there are a lot of restorations, even opposing the tooth you're looking at or next to the tooth you're looking at, it's very difficult to diagnose cracks. And we'll talk about that later on in the presentation. This, I literally just added this yesterday to this presentation. This is typically what I get. This patient was referred to me, ended up treating tooth number 4, as you can see. And this is the exact picture from the radiology report of this patient's CAT scan from the office that referred the patient to me. And I don't even know the brand of the cone beam, but you can look, let's read what the radiologist wrote about tooth number 4. Periodontal ligament space is widened around the apex. Pulp may be necrotic, or PDL space is widened buccal to the root due to occlusal oval or a crack. So first of all, as an endodontist, I'm trying to diagnose whether tooth is vital or not. That's going to dictate whether I do a root canal. If there's a true periapical lesion, the tooth is necrotic, and it definitely needs a root canal. So first they say the PDL space is widened, it might be necrotic. Well, that's the most important thing that we need to know. And we still have to do our sensitivity test. Then it says, so try to rule out clinically any signs and symptoms of a crack. And then it says 1 canal can be traced. So that was helpful. That was really the only helpful piece of information that I got here. And then it says apically, the canal is not visualized right here, due to image artifacts. So it starts off as 1, and who knows if it branched out. So my whole point from it, and by the way, I treated number 4 because it was hot cold sensitive and it was a vital case. So whatever widened ligament they saw was not due to a lesion, which would make it necrotic. My whole point is that you get these 3 or 4 page reports on these scans, and there's really zero information that's helpful, and the images are so blurry. And I hate to even want to take another scan because the patients are very conscious about the amount of radiation. So I'm trying to make a diagnosis off this. And luckily my PA films, and of course, all your endodontic sensitivity tests. Now I want to get into some cases from my practice or from Penn. Dr. Eltom is one of my partners at work. And the PA film came with the patient. And the note from the dentist is that there's resorption on that upper lateral, tooth number 7, where the white arrow is, do the root canal. Now, looking at this, it's strange. It looks like there's something on the root surface. Of course, you always recommend it to take multiple angles to see whether that shifts or not, whether it's something external or whether it's not even touching the tooth itself. But you can make out the canal space. So it's definitely not an internal resorption. But look at this. The axial view here, look at the yellow arrow. It's just pointing to a configuration of the bone. This is the patient's palatal bone. And you can see it here. and especially here, that there's just a little break in the palatal bone. So this has nothing to do with the tooth, nothing to do with an endodontic problem. And the treatment is to do nothing, not to do the root canal because of resorption. So this particular case, very important to take the cone beam to make a clean diagnosis. Another case, very interesting, where the dentist saw this area here with some radiolucency. It looks like it's attached to the mesial buccal root of the first molar. Looks like there might be a little change in the root configuration, meaning it could be some resorption here. Also, the note was to please do the root canal, tooth number 3. CAT scan shows that there actually was a retained root tip that was tucked behind. So what we're looking at here on the axial view is this is the palatal aspect, and we're looking at an area between tooth number 4 and number 3. So here's tooth number 3, mesial distal palatal, tooth number 4. Here is, this would be considered the sinuses at this level. And here is a retained root tip, if you would. And you can see it's all the way palatally, almost perforating out through the palatal bone area. And on this 3D rendering, as I paint away the bone, because you could control the amount of bone on this image, you can see this little tip here. Now, it's typically something that I wouldn't go chasing after. My concern, though, is that you can see there is some lesion around this root tip. So it looks like it's getting infected. Almost looks like it may work its way out through the palatal soft tissue, but this would be something that I'd most likely send to the oral surgeon who'd be a little more comfortable in going after it. Now, here is a case definitely of resorption, but look how innocent this periapical film looks, right? It's tooth number 14. If you look carefully, there's a little break in this pulp chamber here, right? Like there is the mesial distal canal, palatal canal, should be pulp horns in the chamber here. This looks a little fuzzy, no symptoms on this patient, but look at how dramatic the resorptive defect is here on the palate. Obviously, it's very difficult to see what's going on the palate when you look at a periapical film. Before the cone beam, if this tooth became symptomatic, or if I was concerned about something going on inside the tooth, I'd be jumping in doing the root canal. You know what happens when you try to do a root canal on something, or look here on the sagittal view, try to do the root canal, put your file into this palatal canal, and it's just going to be bleeding like crazy, all this granulation type of tissue. If you come at a certain angle, you'll be poking out, you'll actually come out the side of the root. You can see here, to get from this part of the canal past this defect here is almost impossible. And this is actually an external defect. So unfortunately, the tooth is not even savable at something like this. And what you do is you wait, you keep an eye on things, tell the patient eventually they're going to lose this tooth. And as long as they're not losing a lot of bone around it and they're not symptomatic, you can watch and wait a little bit. But if it starts to become symptomatic, you have to be more proactive. And you're saving the patient a root canal by taking the scan and telling them, look, you have to have it extracted with an implant placed. This patient came in with external resorption, 84-year-old asymptomatic. I saw this on the periapical film. And once again, the key to the cone beam is not only diagnosing the resorptive defect, which you can see something going on the PA film, but the second most important thing is the location of that defect. And in this case, the defect, as you could see, is on the palatal aspect. This would be the buccal right here. And you could tell because this is the mesial buccal, and that's the palatal of the upper molar, whereas you can see here this big defect on the palatal aspect of the root. And this is the coronal view showing the buccal view here, and this is the palate, and here is the defect. So a case like this would be very difficult to treat. Question is, do you do the root canal? I'm going to get to that in a minute, where the pulp itself has protective mechanisms against these resorptions from invading the pulp. Pulp kind of removes itself from from the insult of the resorption. These are external defects. You would have to do the root canal. if you're choosing to repair the resorption. So you do the root canal just so you avoid repairing the resorption and cleaning that out and exposing the pulp. A case like this on an 84-year-old patient, asymptomatic, and a very difficult area to reach on the palatal aspect or wrapping around here to the side of the root and palatally. It's very difficult to reach surgically. So I'm going to watch and wait here. And I tell the patient, if it becomes symptomatic, please call me immediately. Here's an example of a case where here's the pre-op. You can definitely see in this particular case, it almost looks like it could be an internal resorptive defect because the canal space is not continuous. It looks like it's bulging out. The cone beam is very instrumental in determining that this is an external resorptive defect. And all it takes is a pinpoint to enter this tooth. So basically what's happening with these external resorptions is that there's some damage to the PDL. And once you damage the PDL, believe it or not, the body starts to look at the tooth structure as a foreign body and starts to eat away at it. I say it's like an old Pac-Man, like munching away at the root structure. And it's going towards the pulp, but it's not pulpal related. These are still vital pulps. But in a case like this, I wanted to be more proactive because I could see it's on the palatal. But if you look at the defect here, it's right underneath the gum line. So I was confident that I'd be able to reach it and repair it. I was worried once I start cleaning this out surgically, I would expose the nerve because you can see here where my arrow is how close it is to the pulp. So what I did was an endo, you could say prophylactic endo or preventative root canal. And then I raised the flap. I was able to clean out the defect. There's the gutta percha and seal it with a Jerry Store, glass ionomer type of material. And there we have a post-op and a 2-year follow-up. So judging from the location from the CAT scan will tell me if I have the ability to repair this before it gets too big and too deep. Now, this is what I was talking about. This is from my chairman, Dr. Karabuchak at Penn, with beautiful case. As I said, I love, this is so cool, where the resorption starts invading the tooth, getting close to the pulp. But the pulp wants to protect itself. It wants to remove itself from the insult of this resorption. And this thin layer around the pulp is predentin, and the predentin does not allow the external resorption to penetrate it. And then if it adds an area of insult to here, then it's going to lay down some tertiary dentin on top of it. So you have the predent. Obviously, I don't have a histology report on this, but this is what's going on there. The resorption starts coming in here, wants to get to the pulp, protect it. So then it goes around here, then it goes around here, it goes around here. And you look at this view here, you could see how the resorption is invading all over, yet the pulp is remaining protected from it. So you could actually see how it just wraps itself literally around, but not invading the pulp. In a case like this, there's no way to be able to restore this. So once again, it's a non-restorable tooth. And sometimes the first thing the patient will notice is a pink color, let's say, because this resorption, like I said, is very granulomatous tissue, a lot of bloody tissue. And sometimes it starts to penetrate when the walls get so thin of the enamel that you look at the patient and the tooth starts turning pink, which means this defect is about to break through out the surface. This case, I just have to show from my practice, seriously, one of the 5 craziest things that I've seen in practicing 30 years. I'm just hitting my 30-year anniversary in August in July of endodontics. So this patient had, the patient had some mental issues and was on the spectrum a bit and used to, as a nervous habit, take his pocket knife and kind of just like wedge it against his teeth. So when I asked him and spoke to the dentist how the patient lost these teeth, the patient literally, over the years of wedging a pocket knife up against the walls of his tooth, had literally extracted some of his own teeth, like literally popped them out of his arch. And this here was damage of this tooth. And you can see here, the reason why I show this is that it's so chronic that the resorption was from him digging a knife into and scraping the PDL. And you can see here, and then he must have gone away from that spot. And with time, what happens is it ankylosis. And ankylosis means it's replaced by bone. So what you're looking at here is a divot taken out of the tooth, and the resorption is self-arresting. So it's replaced by bone. And basically, the tooth is locked in there. It's not going anywhere, but it's tough. You got to just convince this guy to stop, wedging knives in between. But I've never heard of anybody who actually extracted their own teeth. This case I treated in my private practice, and it was one of the first times that I was using one of the newer bioceramic materials to treat this. So let me explain the case. The patient was in his 50s. Actually, I remember because I'm a big lacrosse fan. I played lacrosse growing up. He played for Navy lacrosse back in the 50s. He said he scored a goal in like the NCAA tournament and got whacked. And this was before they had like the big face shield. So he got whacked in the face with a lacrosse stick as a young adult. And when he's in his 50s, he presents to my practice and he has this area of resorption. So had a root canal done, to the best of the dentist ability, had a post and a restoration. And if you look here, there is this buccal defect, right? There's bone loss here on the buccal surface of this tooth. You can see right here, this defect. So what I did was I wanted to repair this surgically because I did not feel confident that I can get that post out and do a better job conventional root canal there. So I raised the flap. What you're looking at here is I did a submarginal incision. Here is the gutta percha in the canal. The resorption actually went into the canal space. So I widened the defect. I wanted to get to clean borders there. And then I placed this bioceramic putty that actually Schein sells through the Brasseler company. It's a BC putty. And this is just another view. And then I covered this with a collagen membrane and closed the flap. Now, the significance here is that this bioceramic material, which I use for all my root end fillings when I do surgery, is now going to be not just at an apex, but on the facial of this tooth in direct contact with the soft tissue when it tries to heal. So that's what makes this an interesting case. So there's my post-op. Here's 6-month follow-up, 1-year follow-up. That looks nice. But let's look at the cone beam. And this is one of the first times that I have seen this. And this was very important. When you're looking at that white arrow, what you're seeing is regeneration of buccal bone right on the surface of that bioceramic putty. So here, once again, is the buccal bone loss at the pre-op. Here is 1-year follow-up showing that this putty is so compatible that bone was allowed to fill up right up against it. Okay, that's what makes this a very interesting and important case. In the old days, I used to use like amalgam, right? Way back when to repair defects or to do apical surgery. And you know that you would never get the amalgam, it was hydrophobic. You always had like scar tissue. This bioceramic is a hydrophilic material and has hydroxyapatite, and it allows for the bone to fill up right up against it. And we'll talk about that in detail later in the presentation. Question: can the cone beams alter your treatment? We talked about some cases with resorption where after taking the cone beam, I knew that I couldn't treat the case. So I did save the patient the problem of having a root canal done. But let's talk about the next topic, which is cracks or fractures. And as I say, as an endodontist, I see this every single day of practice where patients come in with these symptoms where it's a shallow restoration. They're all stressed, especially in COVID times. Patients are very, very stressed out. They're grinding, they're clenching, and they have these intense pain on teeth that look barely even restored. The most common teeth to fracture are the molars, lower molars. So you have the mandibular first and second molars. What's interesting here is upper bicuspids, the second most common teeth to fracture. And my theory behind this is that the upper bicuspids have a fairly large occlusal surface, yet the roots taper and narrow. So there's pretty decent chewing forces on these upper bicuspids, but then the roots are so narrow, thin that they can't absorb those forces and tend to fracture. I see upper bicuspids fracturing all the time. Now, the issue is, can the cone beam really show these cracks? And when you look here on the bottom, a tooth that has either a metal post or gutta percha is going to give off these artifacts, this noise, these scatter here, and this is be the area that you would expect to see the crack. Now, on this particular cone beam, you can see what looks like a fracture line here, but notice that the tooth does not have any root filling in there to cause any distortion. Now, my issue was that before I explored this new Merida X800, I think that a lot of the other brands, if they tried to show better cracks, for example, I found that the images were quite degraded. So in other words, they would take a lot of the contrast, a lot of the sharpness out of the image to try to show cracks. And therefore you had a fuzzier picture, but maybe being able to see the cracks. Now I want to talk about cases from my practice and give you a little bit of idea of what I'm looking for. So this patient comes in, lower first molar, root canal looks good, very well done, and has pain here. Now I'm probing. So the things you're looking for fracture is single deep pocket. So a patient has, 1, 1, 2 probings, and then all of a sudden an 8, a single deep pocket, number one. Number two, if there's a lesion, the lesion is not at the apex necessarily like a root canal problem, but could be lateral part of the root. Or you have the patient biting on this tooth sleuth, which is a bite stick that isolates the cusps. And when they release, it will be painful. So it's like banging a nail into a piece of wood, and you hit the nail long enough and this wood is moving, and all of a sudden fractures. So you're looking for biting pain on release. You're looking for a single deep pocket. You're looking for lateral lesions, looking for some mobility. These are all kinds of signs of a fracture. On this particular case, I didn't see anything unusual. There's no missed canal, no periapical lesion, little bit of buccal bone loss. That could be a crack, but there was no probings. So I raised the flap, and this was very interesting. This is methylene blue. I use this every time I do surgery to look for cracks or look for missed canals or look for PDL. Look very carefully here. The crack extends down the root. This tooth is going to have to be extracted, but it is not continuous with the crown. Almost every time that I have a case like this, I raise the flap and the crack goes from the crown all the way down. That's easy. But if you look here, the crack probably originated apically and worked its way up to this point, not quite up to the crown margin, which is why there was no deep pocket. Very, very unusual. How did this happen? It could even have been way back from when the root canal was done, if they were using spreaders or something that was wedging in this root to cause a crack over here that was propagating from the apex coming up as opposed to from the crown going down. So interesting location of a fracture. Unfortunately, this tooth will have to be extracted. This is the example that I'm talking about, where you see here in the axial view how much scatter or noise there is coming off of the gutta percha, and there's a big post here. And as I said, these upper bicuspids, one of the most common teeth to have fractures, where they get these fat posts placed. The roots are fairly thin relative to a big chewing surface. And what I'm looking at here is this looks like it's a crack coming off this post. And you could also see it here. If I get a probing over here, then it's definitely diagnosed as a fracture. Something like this, I might raise a small flap, although this is on the palatal aspect. But this is something I want to be able to confidently say to the patient, look, you have a fracture here. Therefore, I'm going to save you the problem of having another root canal or a surgery done there and have the tooth extracted. So we need to be able to make a clean diagnosis with these scans. Speaking of clean diagnosis, this is one of the clearest fractures I've ever seen. This was a young boy who did a face plant. Unfortunately, with kids, when they tend to fall on their face, for some reason they like smile and like move their hands, and the first thing that they do is whack their whack their face. But from the periapical film, it looked like it was a horizontal fracture and it was splinted, which is the way to approach this. When the crack is below the bone, so if the bone level is here and the crack is below the bone, you don't do any endodontic treatment. You just stabilize this, take the splint off, and what you'll get is some kind of a fusion, a union here of either connective tissue or some hard bony type of tissue. And you do nothing, especially when it's a young boy like this. You want him to be able to maintain the tooth. I said, let's not be fooled. Let's take a cone beam. We took a cone beam and look at this. So the crack was not as innocent as it appeared in the periapical film, but really wrapped itself around the entire tooth. And if we do nothing here, the poor kid's going to lose bone in this area and get infected. This is going to become a much more difficult situation to deal with. So unfortunately, we had to tell the mother that this poor boy has to have this tooth extracted, have to wear a flipper until he's an adult, and then eventually we'll get an implant there. This patient was treatment planned to do a mesial buccal root resection. Patient already had endo done, and looks like maybe even some surgery here. And the root looks like there's a lesion around the entire root. So we're going to schedule to resect off this root and try to hold on to the crown. Luckily, we took a cone beam first, and it shows that not only is there bone pattern, bone loss in a pattern of a fracture on the mesial root, but the palatal root is completely split in half. Like patient chewed on a piece of dynamite and split their whole palatal root. So this tooth needs to be extracted. We're saving the patient the problem of having a surgery done. And the reason why the cone beam is important is when you look at a PA film of a crack, depending on the angle of the x-ray, it almost looks like there are two fractures here, when in actuality, what you're looking at is the whole crack circumferentially. And I like to see the location here. So what happens is there's a little deviation from the buccal towards the palatal here, and that's why the PA film has this view. But a horizontal fracture like this, subosseous, meaning below the bone, you do nothing. You observe, you let a union form here, and the apical part will always remain vital. If there's any discoloration or problems, sometimes you have to do a root canal on the coronal half of the tooth. And if there's a hard union formed here, meaning an old fracture, you just leave this vital. You don't even get past that crack area. So it's important to have a nice view like this so you know what we're dealing with. And once again, I said, you can see cracks necessarily on films. This patient came to my office, and what was I looking for? I was looking for the bone pattern here. So the cone beam was helpful in showing that the bone loss was wrapping up apically, coming up into the furcation. So this is called a J-shaped lesion, letter J shape, which is endoperio. And then you could see the coronal view of the distal root, the bone loss here. And on the 3D rendering, the visual looks like a crack line. So what I write in my report to the dentist is the bone loss is suggestive of a crack. There's also a missed distal buccal right here where my arrow is going. Do you try surgery or retreat, or most likely fracture most likely extract because of the fracture here? So my differential diagnosis would be fracture with the recommendation to extract the tooth. And once again, the bone loss here is suggestive of a crack. And in this case, the patient wanted to be 100% sure. So I said, fine, I'll go in to the tooth and we'll look. And if there's no crack by some miracle, I'll retreat it. But sure enough, when we get in, you can see the crack line going down the axial wall. These are just two views that I took through my microscope. And you can see the crack going down all the way to the gutta percha. So that confirms that there's a fracture. And I just close him up and send him to the surgeon or back to his dentist or periodontist to get the tooth extracted with an implant. And finally, just two cases of teeth on adults that I was able to see cracks. And oftentimes you can't really tell when a tooth is restored or has, root canal and crown. This particular patient is actually a friend of mine. He's in his 50s. He's right around my age and has virgin teeth here. And he comes to me, pain. I couldn't diagnose anything. A few months later, he has this fistula. I try to trace. And I take a comb beam. I'm like, wow, he really did a good job splitting this tooth in half. But this is so clear because there are no restorations in this quadrant and no opposing restorations. That made it easy to make that diagnosis. All right. The last topic I'm going to move on to is using the cone beam to show bone healing. And I want to talk about this bone grafting product that I've been using for many years called Foundation. It's originally designed to be used for ridge augmentation or for extraction sites. When I got my first cone beam many years ago from Arita, they gave me a free box of the stuff to try. I've been using it ever since. I use it on my endoperio cases when I'm doing surgery, and it's inexpensive. These are the prices. This is the bullet that it comes in. To be honest, a medium-sized bullet like this, in a sterile environment, I could cut this into halves or thirds and use it in 3 different surgeries. And it looks like a cotton roll, styrofoam cotton roll. And then when you moisten it, it becomes gelatinous and very easy to be able to manipulate and move. And what I love about this is that it's radiolucent. So when I'm done doing a surgery, instead of having a granular type of product in there, that looks like bone, but it's just bone grafting material, then you don't know when they take an x-ray a year later. Is that bone that's healing in, or is it still the, bioos material, the bone grafting material? With the Foundation, it's radiolucent, and therefore you can't see it on the x-ray. So when you see radiopacity in the future, that shows that it's bone and it's healing. And it's made of bovine collagen, which is a very big supply. And it's inexpensive and very easy to place. So, and it has supposedly, chemotactic effects to help to not only allow bone to fill in, but to attract new bone cells. Now, I'm going to be showing a bunch of cases after this, but I want to talk about something that I find very interesting. And Dr. Kim and I just published this in a textbook back in 2017 about healing in 3 dimensions, because obviously before cone beams, all you could talk about is healing on a periapical film, which is 2-dimension. So there were a lot of classic studies in root canals back from the 70s from Rudd and Mulvin talking about incomplete or uncertain healing. But I want to show just this. This is 3D healing according to what we call our Penn criterion, where you have a continuity of the cortical plate, but then there's an interruption where the osteotomy is made. So this is a tooth representing when we do a surgery, we're cutting a hole in the bone to get to the root, shave off the end of the root, and do a root end filling. So it's an apicoectomy. We want it to heal completely, but you can see here that the bone is starting to heal back in, but there still is this little break in the bone. Next up is you have this area of low density, which is the exact shape, this triangular shape, is what you make with your burr when you're doing your osteotomy. So it's definitely not as dark, not as radiolucent as when you did the surgery, but you can still make out the area that you worked. Or you have these cases where the bone starts to fill in, but then doesn't fill in fully across the root surface. You can see bone filling in right at the part of the root here, but not fully here. And this to me is the most fascinating, where the cortical bone reforms, which is typically the most difficult part of healing, to get the cortical bone to reform, yet you still have this area of low density around the root itself. And all these we coined limited healing. Okay, so that's what I just want to use as the basis for all the cases. This was in a cosmetics store that I saw one time, talking about foundations. Let's talk about the future of foundation. The next 2 cases I want to share with you. Dr. Amina is a 3rd-year master's student in our endo program, sweetheart of a lady, great resident. She's from Kuwait, and she's doing her master's thesis on bone healing. And we did a double-blind study I just actually participated in looking at the healing, and that's what I'm sharing with you. This is unpublished, okay? So this is yet to be published. So I'm just going to give you some preliminary findings. Please don't quote me on anything. Let's hope that she gets accepted into one of the endo journals soon. But did a double-blind study. After doing the apicoectomy, basically you're flipping a coin, and either you're placing foundation graft into the site or the control is nothing at all, okay? And we wanted to track healing with the foundation, and more importantly, not just healing, but whether you're going to reform the cortical bone, as I said, which is the most important part and often the most difficult part. So here is the pre-op. This is cone beam slices, post-op, 1 year follow-up. Look at the comparison between the lesion here and the healing at 1 year, great. But I want to focus more on the cortical plate that I'm showing right here on the pre-op. There was a break in the cortical plate. And here, because foundation was placed in here, and you can see the cortical plate is reforming over here. That's the key. We're looking at the reformation of the cortical plate with the assumption once the cortical plate reforms, then that makes for much, much more predictable healing within the lesion itself, okay? Next case is an upper molar, mesial and distal root. And you can see, once again, pre-op, post-op, 1 year follow-up. So look at the pre-op of the lesion around the mesial root and the distal root, different angles here. And now let's compare. And once again, here is the pre-op cone beam. Here is the 1 year follow-up on the mesial root. You have healing, but we're going to focus on here where the big white arrow is. Once again, distal buccal, great healing. And we'll focus here. And I want to look at this. So if you look at the two white arrows, this is showing that the cortical bone reformed over the root surface. Now, one of my hypotheses is that the more tilted the root is towards the buccal, the more difficult it is to get this bone to reform. By that, I mean, if the root is straight up like this, and to begin with, you have cortical bone, but a big lesion, then there's much greater chance of cortical bone reforming after the surgery. When the root is tilted buccally like this, it's great when you get this cortical bone to reform. And you see it's still a little bit hypodense, but what the preliminary results are is that, and as I said, this was a blind study, random whether we used a foundation or nothing at all, that it seems like the foundation tend to have quicker healing and more cases where the bone reformed over it. And if you look at a famous surgeon, Van Arx, does a lot of studies on surgery. He calls this Van Arx classification 2, meaning reformation of the cortical bone without a break. It's a continuous reformation of the bone. Now let me show my clinical cases from my practice. Patient came in years ago with this lower molar, very nice looking root canal with a lesion. Classification C means that the lesion is wrapped around the apex of the tooth, starting to work its way up around the root, but good crestal bone, so there's no perio component. I cleaned out the defect. Here is the mesial buccal, mesial lingual at the apex, looking through a micro mirror. I prepped it with ultrasonics, and back then I was using a gray MTA material. Here's my post-op, 8-month follow-up, nice healing. Patient comes back 6 years later, pain, and looks like my filling washed out. So I take a cone beam 6 years later, and you can see this defect in the bone. And once again, this root is leaning out towards the buccal bone. And you can see this is from the old osteotomy, if you would, and it didn't heal. I say this is my GPS, meaning I know when I raise a flap, I'm going to do my apical osteotomy at 9.43 millimeters from the crown. And then I know I have 6 millimeters to go from the buccal through the mesiolingual. So I'm using this cone beam, very important to gauge what I'm going to do during my surgery. Here's my second surgery. This is now classification F. And what that means is there's a complete fenestration. So if you remember, there was bone covering this part of the root 6.5 years ago. Now there's complete fenestration. My material washed out. So I re-cleaned it, re-prepped it, placed the bioceramic putty. Then I placed this foundation. So the foundation looks like a styrofoam plug, if you would. You moisten it with saline. then you mush it in there, and now it fills that space. If you want to cover it with a piece of collagen or some membrane, you can, but this actually can act as both a graft and a membrane. There is the post-op of the surgery, 10-month follow-up, 2-year follow-up. So look at how nicely the bone has healed in. And let's compare the second surgery pre-op with a 2-year follow-up to the second surgery. And once again, this is that Penn criteria of limited healing where completely filled in with cortical bone and maybe a slight area of hypodensity, meaning a little bit of elucency. But look at the difference. Look at how well this healed over the 2 years and how the cortical bone reformed, presumably with the help of this foundation material. In this case, I like the very interesting case. Patient had an apical surgery done by another endodontist. Mesial root, looks like it was cut, but they didn't address what we call an isthmus connecting MB1 and MB2. I took a cone beam and I said, look, you have a lesion here. Looks like the other endodontist shaved off the end of the root, but I think that they should prepare this and place root and filling there. I said, I'm happy to do it for you, but you might want to go back to the first endodontist out of courtesy. So he went back, he did a second surgery. And I don't know why, but instead of going from here to here, he went from here to here. The actual second canal is here. Now I said, let me take over here. I raised the flap. Here is mesial buccal 1. This was a perforation. The other endodontist, for some reason, his orientation was thrown off and was going in the wrong direction. There's the actual MB2. So I'm going to shave off more to get rid of this perforation, connect the dots, MB1 and MB2 with an isthmus. This foundation, once again, I plug into the hole there. And what the foundation does is it holds the blood clot in place and acts as kind of like a sponge to prevent, to allow for that blood clot to mature and to dissolve. The foundation will resorb in about 2 months to 3 months and hopefully replaced by bone at that point. So it acts as a scaffold, if you would, to allow new bone formation. Sometimes I just cover it with a piece of collagen there to prevent the soft tissue from collapsing. Post-op, 1 year follow-up, and you can see complete bone fill over there. And now we have my 1 year follow-up to the surgery on 3D. And you can see I addressed the isthmus connecting MB1 and MB2, and we got complete healing over here. This also classification E, where you can probe from the furca down to the apex, yet there is a little bit of crestal bone. So F would be complete fenestration. E is endoperio because there's probing, yet there is some crestal bone here. So once again, I did the root and filling with the Bioceramic. What I want to show here is this foundation is very movable. It's easy to push up into this area. So I place the foundation into the apical portion, and then as it gets soft, I move it up and I could push it up into where that furcation area is and then get a good seal there. Here we have, I'm sorry, I have to go back. So here we have the post-op and then 8-month healing beautifully, and there are no more probings. Last 2 cases I'll go through real quickly. Endoperio lesion, classification E, where you probe from the apex, from the furca down to the apex, but there is crestal bone. And this shows how far tucked in it is. And I wanted to show that because this really shows with the foundation here and the follow-up, how when the root is tucked in, this is the distal root of a lower first molar, not only do we get good healing here, but we get complete reformation of this cortical plate. So this once again goes back to my theory of when the root is placed deeper into the bone, that it makes for easier healing. Last case, and you guys have been a great audience, and I'll be opening up for questions in just a couple of minutes. So I believe Adam is fielding the questions from you, and then I'll be happy to answer any questions. Patient comes in with this lesion wrapping around the mesial root, a little bit of lesion on the distal, but let's focus on the mesial here. And you can see I was worried that there was a fracture due to the location of this lesion. I plan on doing apical on both mesial and distal. Let's look here. I raised the flap. Here's the mesial root, mesiobuccal, mesiolingual, and a mid-mesial canal. So I'm going to connect all these dots and put a root and filling. This is a question mark. This is that J-shaped lesion, that endoperial lesion. Looks like this line maybe is a crack, or is it a lateral canal, or what's going on? Not sure. I do the root end fillings on mesial and distal. I place the foundation in here, and then I shove the foundation up into the mesial aspect of the root where that potential crack line is, or potential lateral canal, to seal it. And then I put another piece of foundation apically. Here's my post-op 13-month, 25-month, 3-year follow-up. At 3 years, I take a second cone beam. The distal root has complete healing, maybe a little area of hypodensity. I want to focus here. So I was concerned because the mesial, great improvement if you look at the pre-op versus here, but this was bothering me because the patient had reformation of the cortical bone, which is great, but I was nervous about this. This looked kind of lucent to me. So I sent this 2 cone beams to my dear friend Bruno Azevedo, who's down in Louisville, and a radiologist and a great friend, an expert on cone beam. And he superimposed my 2 cone beams, and he developed this new software. And this software actually can take slices of this. I'm going to go fast here. Take slices and show where the lesion is coming from. And look here, he almost pixelates this. And that is a lateral canal. This is very cool stuff coming off of that root, feeding into the lesion. So these are slices that he's put into this new software that he has. And he assured me by comparing the 2 scans that that was actually spongy bone, or it was new bone that was being formed. So what Bruno did was he took this area here. This is that mesial root. And here's a slice. And you can see this large lateral canal going right into the area that I was worried that was a fracture, and actually was healing. So that was very cool stuff. And I hope that all of you at some point in time, or you may have already, had the pleasure of listening to Bruno speak. So with all that, I want to say thank you very much for your attention. Besides being an endodontist, I am a professional bartender. That is true. I paid my way through dental school by bartending in New York. And this is the bar in my house. So if any of you on here, I know there are a couple hundred of you listening in, happen to be in the Philly area, the good thing with my bar at my house is that it never closes. It's open 24/7. So with that, please ask any questions. And I'm going to open up the mic back to Adam. And I want to thank everybody for staying with me for these 50 minutes. Thanks, guys.
I tell you what, that's my kind of bar. Might be stopping by next time I'm in the area.
There you go. It's always
let's see. Yeah, we got a couple minutes left for questions. So if anyone has them, drop them in the Q&A and we'll get to them. Let's see. Some of these were specific to cases you just showed. So the first one is,
I could go back if you need.
Yeah, the first one says, is that real bovine bone in the plug? Not sure if you can do anything with that.
Well, it's so the foundation is bovine collagen. Okay, is that what you're saying? What the material is? Because
if I had to guess, yeah.
Yeah. So I'm sorry. So I don't mean to go fast over it, but on the insert for the foundation, it's collagen made from bovine atelocollagen, which is the process of it from the Achilles of a cow. So it's collagen. It's not bovine bone, but it's collagen from Achilles tendon of cow. Right, what I'm saying is that when I see healing, and I'm saying when I see an X-ray follow-up and it's radio opaque, then I'm assuming that that site is filling in with bone. My issue with some of these other grafting materials is that the material itself is radio opaque. So when you look at follow-ups a year later, 2 years later, 3 years later, and I know this because I've re-entered these sites, and you see radio opacity 3 years later, are you looking at bone, or are you looking at a mixture of bone with this radio opaque grafting material in there? I think that kind of my point, but I'm not sure if that's what the question was referring to.
Another one, potentially on the same case or a different one. It says, could we use that material for a regular socket graft? And if we did, would we not need to place a membrane or plug on top?
Okay, great question. It was actually designed for oral surgery for socket preservation. So it was originally designed to be placed in a socket, and it claims that you can place an implant sooner, meaning it has chemotactic effects to not only allow but promote quicker bone healing so that you can place an implant sooner. You do not have to cover it with a membrane if you choose not to. It can be exposed to the oral environment. So it's designed to be placed inside a socket or for to help with ridge augmentation prior to implant placement. So the answer is yes.
Would you recommend GPs taking cone beam images routinely on patients at their initial comprehensive exams?
That's a very tough question and a great question. I'm afraid sometimes cone beams are taken unnecessarily, and we can't, blow off the amount of radiation. Now, the cone beam CAT scans are limited fields of view, so it's much less radiation than when, like, a surgeon is taking a full mouth CAT scan if they're doing implants, for example, or multiple sides. Now, I take a cone beam for every surgical case. I take a cone beam for every retreatment case because I want to see, is there missed canals? What's the bone look like? Is there potential for cracks of various reasons? And then those tricky diagnostic cases that I talked about, cracks, fractures, resorption. Now, would you take a cone beam for every case? I guess the answer is no, because you really only get a clear view of about 3-4 teeth. So if you're treatment planning a patient and there is a tricky diagnostic area or problem area, then yes, you can take a cone beam. But I would criticize that it would be way overkill if you're just routinely taking it. I don't even routinely take it for every root canal case. I mean, if you have a cavity that's exposing the nerve, and I know how many canals I'm looking for, then I don't take it for even routine root canal cases.
Does it need a membrane when we have through and through lesion?
So a through and through lesion means that it's going both through the buccal and the palate. Those cases do have lower success rates because you have less areas for the cells to fill in. So yes, you do need grafting and ideally membranes. Now, I have cases where I raise a buccal flap and I'm able to tuck a membrane in, and I would use a thicker membrane, something called like A6 Plus, or something that's a little easier to manipulate, and you can actually tuck it behind the root. I mean, ideally, you'd have to raise both a buccal and palatal flap and place the membrane over the bone palatally, and then sandwich in the grafting material, and then place a second membrane buccally. So you're making like a sandwich of bone grafting material. But I've been doing these cases where I'll tuck a membrane behind the root, and then I could place foundation, and then you could put another membrane on the buccal. Through and through lesions have lower success rates, much trickier, but it's definitely recommended to graft and membranes with those cases.
I'm wondering why foundation helped save one J-shaped lesion, but the other J-shaped case was extracted.
So the couple of J-shaped cases that I showed that we had extracted were due to fracture, meaning if I don't want to confuse everybody, if I have a cone beam that shows a J-shaped lesion and I'm probing 8 millimeters and it's hurting with the bite stick, and I feel that there's a great chance of it being fractured, I'll either tell the patient it's less than 50-50 chance to save the tooth. Or if you really want me to know for sure, I'll open the tooth up and look internally for a crack or raise a flap and look for a fracture. The cases with the J-shaped lesion that it worked with the foundation was because there were no fractures. So before I schedule a surgery, I have to probe the patient. And if there are no probings, yet there's a J-shaped lesion, then it still could be a purely endo with a secondary perio, and I can still get healing there. But when I raise the flap and do surgery, I'm taking the photos that I'm showing you guys. And if there's a crack that I see surgically, then I'm going to show you that after the surgery and tell you, look, I found a fracture. I still cleaned up the granulation tissue, but unfortunately, the tooth's going to have to be extracted. And I don't charge a full fee. I just charge a nominal exploratory fee if a tooth has to be extracted.
All right, let's see. A couple more questions here. Is it possible for a canal starting on pulpal floor above furcation and ending in the furcation?
Yes, what I think what they're referring to is accessory canals. So there are tiny accessory canals. If you look at 3D of what a canal space looks like, there's no just single canals. I mean, everything has tons of lateral and accessory canals, and the large accessory canals can go from the pulpal floor to the furcation. So that's why it's critical that because we're not mechanically instrumenting those, that's why it's critical to use a lot of irrigation. There's gentle wave out on the market where it's really flooding the chamber area and the canal space with the irrigants. But irrigation, so it's a chemical and mechanical cleaning of the roots to get the best chance in order to clean these areas out. But yes, there are lateral canals that go from the pulpal floor down to the furcation.
Got a couple questions asking if you can repeat the name of the bioceramic putty.
So it's called BC putty, bioceramic putty, and it comes in a syringe from Brasseler that you can buy through Schein. And I personally like the syringeable one because it is a fast set putty, and I could get probably 10 to 12 surgeries out of a syringe. And I also use it for perforation repair and some resorptive defects depending on where they're located. So it's a BC putty and comes in a syringe. You can get a fast set or you can get a tub, but I like the fast set 1 gram syringe.
All right. The endodontist I work with now tells me he takes a pre-op cone beam for every endo. Would you consider that appropriate?
It's tough to say. If it is a routine case that, well, first of all, every molar case that you could say, well, I don't know whether it's going to be 3 or 4 canals, so I want to take a cone beam to see the canal configuration. If it's a tooth that you can clearly see the canals, if it is an anterior, or even lower anteriors, it might have a second canal. So the endodontist that you're working with may justify it by saying they want to see the canal configuration and know the number of canals. Personally, and this is just a personal, I think that's a little bit overkill. But I do know people, endodontists, that will take a pre-op cone beam on nearly 100% of their cases.
Can you bill medical insurance for CBCT for trauma, like a child that face plants?
No. If the child that face plants goes to a hospital setting to get wired and done by an oral surgeon, they may do something through medical, but I've never received any reimbursement from medical for any type of cone beam, regardless of the reason, but I wish I did.
One person says, sorry, is that putty different from the foundation product?
Oh yeah, foundation is a collagen grafting material, And the putty is actually what I use in the root itself. So I use the BC putty inside the canal space at the end of the root, and then I fill the osteotomy site with the foundation.
Excellent. Thank you. Well, thank you, Dr. Kratchman, for the great presentation, super engaging. And of course, thanks to Marita for sponsoring tonight's webinar. If anyone has additional questions about CBCT in endodontics, please feel free to email us at webinars@henryschein.com, and we'll be happy to answer your questions. Additionally, if anyone is interested in attending future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. As a thank you for attending, everyone will receive this recording via email sometime in the next week. So I'd like to thank you all for joining us, and we hope to see you back here soon. Have a great night.
Thank you, guys. Thanks, Adam.
Thank you.